Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features content from an educational webinar titled Key Studies Influencing My Practice following EACS 2021, featuring Dr. Tristan Barber. Dr. Barber is a consultant in HIV medicine at the Ian Charleson Day Center at the Royal Free Hospital, an honorary associate professor at the Institute for Global Health at University College London in London, United Kingdom. In this episode, he discusses data presented at the conference, including on first-line therapies, switch strategies, long-acting therapies, and COVID vaccine efficacy and the impact of the pandemic on viral suppression in people with HIV. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Barber has to say about new data from EACS 2021.
It's a great delight to be here giving this presentation, and welcome to all of you wherever you are in the world. So this is our program overview. We're going to run through some data from EACS, talking first of all about first-line therapies, covering bictegravir, FTC, and TAF in a test and treat model. We're going to be looking at phase 2b data on islatravir and doravirine in treatment-naive people out to 144 weeks. We're going to be looking at switch, mainly looking at dolutegravir and lamivudine in patients with a history of the M184 mutation. These are data sets from France and also from the USA. And we're going to be looking at long-acting therapies, mainly based on injectable cabotegravir and rilpivirine, but also looking at the resistance and subgroup analyses of long-acting lenacapavir in highly treatment-experienced people with HIV. And then, if we've time, we'll end looking at COVID-19 vaccination efficacy and the pandemic impact on viral suppression in people with HIV. Now, there is a lot of data here to get through. If we do go through some things quite quickly, you will be able to download all of these slide sets after the presentation. So first of all, I wanted to look at first-line therapies. This is the FAST study looking at the efficacy and safety of bictegravir, FTC, and tenofovir alafenamide co-formulated in a single tablet in a test and treat model. Essentially, this is a comparable study to the STAT study that was conducted previously looking at dolutegravir and lamivudine in a test and treat model. And this is a prospective single-arm study that was conducted in France with 112 participants. People tested for HIV, and if they were found to be positive, they were started immediately on the combination regimen at their first medical appointment following the positive test, without other baseline test results being fully available. In practice, this meant that about 98%, if you look at the bottom of the baseline characteristic table, was started on the first day after diagnosis. The primary endpoint was an FDA snapshot analysis of the proportion that were undetectable with a cutoff of 50 copies per mil at week 24. And you can see the other baseline characteristics described in the table. There was actually quite a high proportion who had a very high viral load, suggesting very early HIV infection, about 19% having a viral load of over 500,000 copies per mil. And these were the outcomes. You can see at week 24, the proportion with an undetectable viral load, so the primary endpoint as defined, was 80.4%. The proportion that had a detectable virus above 50 copies was 9.8%. And you can see that 8% had other reasons to not meet the primary outcome, and just 2 participants had a serious adverse event. Now, if we look at the viral decay curves on the right here, you can see the decay in those with a viral load below 100,000 in blue, those with a viral load between 100,000 and 500,000 in orange, and the very high viral loads in green underneath. And you can see that obviously you had a lower chance of being suppressed at week 24 if your baseline viral load was very high. But nonetheless, if your viral load was below 100,000 copies in blue, we get the viral suppression that we would expect from a regimen based on bictegravir of around 89% week 24. Now, importantly, as we've become familiar with second-generation integrase inhibitors, there was no treatment-emergent resistance seen through week 24, and there was a low incidence of grade 3 or 4 adverse events, or indeed serious adverse events. In terms of take-home points, these results suggest that this combination is safe and effective for same-day antiretroviral initiation in a test and treat setting. And I think if we compare to the STAT study, we obviously don't have to worry so much about people who may have had hepatitis B co-infection that wasn't being picked up. This combination was 80% effective in suppressing viral load at week 24, although those with a higher baseline viral load took longer to suppress. And there was a low incidence of grade 3 and 4 safety events. Importantly, no emergent resistance-associated mutations were detected in those who were not undetectable at week 24. I want to look at some other naive data now. These are data on islatravir and doravirine in treatment-naive people with HIV, now out to week 144. Now, these studies were initially quite complicated. They were dose-finding studies taking treatment-naive HIV-positive adults with viral loads above 1,000 copies, CD4 counts above 200, no antiretroviral resistance, and no hepatitis co-infection. And they were randomized to one of 4 arms, and many of you will be familiar with this already. These had doravirine and 3TC, and then 3 different doses of islatravir, compared to one arm, which was the fixed dose combination combined single tablet regimen of doravirine, lamivudine, and tenofovir disoproxil. And this went on till week 24. There was then another extension phase in part 2. And after that phase, the 3 islatravir arms all rolled over to receive islatravir at a 0.75 milligram dose. Important difference between week 24 and phase 2 was the fact that the 3 islatravir doravirine arms dropped their lamivudine, whereas in the single tablet regimen, you continued on doravirine, lamivudine, and TDF co-formulated in a single tablet regimen. Now, these studies have already shown high rates of efficacy and tolerability through to week 96, and no patients met the criteria for resistance testing. If we look here just on the right-hand side, rather than the 3 different islatravir dosing arms, we can see the combined islatravir doravirine arms, and we can also see the single tablet regimen arm in orange. You can see that, like many antiretroviral studies, this was predominantly a male population. It was quite a young population with a median age of around 28 years, and the majority of the population was white. About 3/4 of participants were white, with other ethnic backgrounds given here in the table. Now, importantly, these are the virologic outcomes at week 144. And again, highlighted in the red boxes here, we can see the combined islatravir arm in the blue, and we can see the single tablet regimen, the 3-drug regimen in the orange. And you can see viral suppression rates out to 3 years of around 72 for the combined islatravir doravirine arm to 77% in the single tablet regimen arm. In terms of the proportion that had a detectable viral load at week 144, you can see this in the middle here, about 7.8% in the islatravir doravirine arm and 3.2% in the 3-drug arm. And you can also see on the right the proportion with no virologic data at week 144. Now, this trial had very stringent criteria for virologic failure. In terms of protocol-defined virologic failure, this was a confirmed HIV RNA that was above 50 copies per mil. This was found in 7 patients, and all of them were withdrawn from the study with a confirmatory HIV viral load of less than 80 copies. Now, this is great for a very stringent study, but it doesn't tell us much about what would happen in people in clinical practice who failed this 2-drug regimen, all acting at reverse transcriptase with higher levels of viremia. So they all discontinued the trial with a confirmatory viral load that was quite low. There were no instances of clinically significant confirmed viremia above 200 copies per mil or any consequent viral drug resistant analyses. In terms of safety outcomes, again, you can see this on the right-hand side here. The most common drug-related adverse events were diarrhea, nausea, headache, and abnormal dreams, but there was a far lower rate of drug-related adverse events in the dual therapy arm, 7.8% compared to 22.6% in the triple therapy arm. It was also noted that all discontinuations due to drug-related adverse events occurred prior to week 48, and that there were no deaths or serious drug-related adverse events across the dual therapy arms. In terms of take-home messages here, we can see that islatravir with doravirine demonstrated non-inferiority to doravirine, 3TC, and TDF in maintaining viral suppression through week 144. None of the study participants met the criteria for resistance testing, and the 7 that were withdrawn because of virologic failure all had very, very low viral loads. There was good overall tolerability, and a low rate of discontinuations due to adverse events. Moving then on to switch. Now, quite contentiously, some data sets were presented looking at the role and the efficacy of dolutegravir with lamivudine in patients with a history of an M184 mutation or previous virologic failure. Now, I say contentious because I think people are starting to consider whether it's ethical to undertake these studies if people have other antiretroviral options. Nonetheless, I do think it's interesting to look at the outcomes of dolutegravir and lamivudine in people with an historical or a suspected M184 mutation. Now, you can see in the SOLAR 3D study, this was a prospective open-label comparative trial. People could be receiving 3-drug antiretrovirals, 2-drug antiretroviral therapy, or 4-drug antiretrovirals, with the majority receiving 3-drug ART. And this study enrolled adult patients who were undetectable, who were on their regimens for at least 6 months, who had had earlier virologic failure, or had not suppressed on a previous regimen, or had a confirmed failure above 200, and or had documented genotypic or phenotypic resistance to lamivudine. And then these people were stratified 1-to-1 according to the history of their M184 mutation to receive dolutegravir lamivudine. Apologies. So they all received dolutegravir lamivudine. The stratification was whether they had an historical M184 or they did not have an historical M184. The data on the right-hand side is a little bit confusing, but what we're saying here is that 50 people were entered into the arm with an historical mutation, and 50 were entered into the arm without an historical mutation. Of those, 41 in the historical M184 arm underwent proviral sequencing, of which 15 had the M184V or I mutation present at study entry. Now, 26 of those in the M184 arm who underwent proviral sequencing actually did not have the M184V or I present in that proviral DNA at study entry. If you compare this to the no historical M184 arm, in this arm, 29 people underwent proviral DNA sequencing, and of those, the M184 was absent 100% of the time. So quite a complex data set. The primary endpoint here was the proportion of patients with a detectable virus above 50 copies at week 48 by the FDA snapshot intent to treat and per protocol analyses. And you can see the outcomes here. So if we look at the proportion that did have a detectable virus, you can see that actually you are more likely to have detectable viremia above 50 copies if you were in the orange group, which is the group that did not have an historical M184V or I mutation. And in actual fact, if you had an historical M184V, you were very likely to be well suppressed. If we then look at the proportion that were undetectable in both the intention to treat and the per protocol analyses, you can see that the group with an historical mutation did very well with good virologic suppression rates compared to the other arm. Importantly, again, no cases of treatment emergent resistance were seen through to week 48 in either arm. So moving from that American data, we then moved to the French cohort study that was presented. This is a retrospective analysis of switching to dolutegravir and lamivudine, again in people with an archived M184 mutation. The primary outcome here, again, was the instance of virologic failure with a viral load above 50 copies, or that was confirmed, or a single HIV viral load above 200. And this was according to the presence of an archived M184V or I mutation. Of nearly 700 people who were switched to dolutegravir and lamivudine while they were suppressed with a prior genotype, 15% had an archived M184 mutation. Now you can see this broken down in the colored lines in the graph underneath. The orange is the group without a 184. The green is the group with a 184 that had been detected within 5 years before the switch. And the blue is the group that had an M184 mutation detected greater than 5 years before their switch to dolutegravir and lamivudine. The median follow-up in this cohort was 1.2 years, and there was no significant difference seen in the probability of virologic failure in those without an M184 compared to those without an M184 mutation. And this included no difference according to the time of M184 detection. So these studies both had relatively small numbers of people with an M184 mutation, but the studies did not distinguish between the M184V or the M184I. But nonetheless, in both studies, there was no significant difference in virologic failure rates based on the presence of the M184 mutation for those who switched to dolutegravir and lamivudine whilst virally suppressed. Now, for me, what you really want to see here is longer follow-up. You want to know whether these people have a shorter time to the loss of virologic response. Certainly, if we look at the studies presented here, the follow-up time was quite short. And I think to really stress test this option, we need to see much longer follow-up. Moving then to long-acting therapies, and starting really with injectable cabotegravir and rilpivirine, these were data from a combined analysis presented by Emily Elliott from ViiV, looking at the effect of BMI in the studies that had looked at the efficacy of cabotegravir and rilpivirine. These were merged data from 3 phase 3 studies, the ATLAS, the FLAIR, and the ATLAS 2M studies. These were pooled for participants naive to cabotegravir and rilpivirine who received this injected at either an 8 or 4 week dosing schedule. Participants were categorized according to their dosing regimen, whether they were given 8 or 4 week dosing, and also according to their BMI, so whether they were under 30 or whether they were over 30 at study entry. These were the combined baseline characteristics. Essentially, there is not very much difference between these groups, apart from the fact that there is an association with higher BMI and race. If we then look at the combined clinical trials of these agents and the efficacy by BMI class, we can see that there was really quite good efficacy. The proportion that were undetectable, above 90% in all of these breakdown categories. But if we look at the proportion that were detectable, this is higher in the higher BMI arm. Now, what's important here, and many of you again may be familiar with these data in the past, is that having a BMI above 30 as the only risk factor did not mean that anyone met the criteria for confirmed virologic failure. And other risk factors for failure have previously been presented, including having HIV subtype A. But having a high BMI alone did not seem to increase your risk overall of virologic failure. These are the data here that look at the trough levels from this combined analysis by the dosing regimen. You can see in the solid lines, both blue and orange, people who had a BMI of less than 30, and in the dashed lines, you can see the people who had a BMI that was greater than 30. Rilpivirine trough levels are given here in blue, and cabotegravir are given in orange. And I think you can see that the lines are really superimposable. What was presented is that in participants with a high BMI of above 30, the use of longer 2-inch needles did result in higher median cabotegravir trough concentrations. And a recommendation was made that longer needles should be used in people with a BMI above 30. Take-home points here was that both cabotegravir and rilpivirine at 4 and 8 weekly dosing maintained high virologic suppression rates through to week 48 and were well tolerated regardless of baseline BMI category. No participant, as I've said, with a BMI greater than 30 as the only baseline risk factor for virologic failure met the confirmed virologic failure criterion through to week 48. And as we've said, longer needles may be warranted in those with a higher BMI. There was also some data presented looking at the long-term follow-up of participants who discontinued long-acting CAB and rilpivirine in the clinical trials. Now, from these, about 150 people discontinued, 114 from the 4-weekly dosing schedule, and 36 from the 8-week dosing schedule. We know that 8 weeks is generally preferred by participants in these studies. The median duration of exposure to the long-acting treatments before they entered long-term follow-up was about 36 weeks. So most of them did not leave the studies until that time point. And of those who discontinued, 38% entered long-term follow-up after 1 year of long-acting therapy. The reasons for withdrawal were very rarely due to lack of efficacy, sometimes due to an investigator decision, but by far the most frequent reason was withdrawal by the participants themselves. Common reasons including tolerability of injections, frequency of visits, relocation, so moving away from their study site, or the burden of study procedures. The participants primarily switched to INSTI-based regimens, most commonly dolutegravir. You can see 60% receiving an INSTI-based combination following discontinuation from injectables. In terms of virologic efficacy, of the 150 participants who entered long-term follow-up, 91% of those who completed out to month 12 were virologically suppressed, including 88% of those who entered long-term follow-up after virologic failure on long-acting cabotegravir and rilpivirine. So approximately 9% of participants discontinued long-acting CAB and rilpivirine and entered this long-term follow-up phase. The most common reasons for entering the follow-up phase included discontinuation due to adverse events and participant withdrawal. High rates of virologic suppression were observed on subsequent therapy, regardless of the reason for entering long-term follow-up. And no efficacy or new safety concerns were observed in participants who switched to oral antiretroviral therapy, regardless of the reason for switch, even during the period of declining CAB and rilpivirine concentrations as those injectable agents waned. We also had more data presented from the CARISEL study. This was an interim analysis of patient satisfaction with long-acting CAB and rilpivirine. This is an implementation study, so it's open label, a phase 3B study, and recruited 430 virologically suppressed people with HIV to receive long-acting CAB and rilpivirine injections in 8 weekly dosing. And this was in 18 clinics across Europe, in France, Spain, Belgium, Germany, and the Netherlands. The interim analysis included data from patient surveys performed at month 1 and month 4. So this was before the first and before the third injections. And the satisfaction with the treatment was assessed. The acceptability, appropriateness, and feasibility of the regimen was also assessed. And additional questionnaires were used to evaluate the attitudes and expectations regarding the regimen that they were receiving. Now, you'll be familiar with these, and it's always disappointing to present this because we're trying so hard to increase the diversity of recruitment into trials. But the patient population here was primarily male, 81%. 75%. They were over 35 years of age, was the 81%. And they were predominantly white, 78% being white. Now, you can see here the acceptability, the appropriateness, the feasibility, and the satisfaction with long-acting cabotegravir and rilpivirine. Most participants found it acceptable, appropriate, and feasible, both month 1 and also at month 4. And the satisfaction scores in total increased over time, with most patients being satisfied or very satisfied with their treatment. I think it's always important to remember that these are people who've opted in to an open label study to receive injectable treatment. But this really reflects what will happen in clinical practice. We're not going to be giving this to people who don't want to switch to injectable therapy. It will be a selected group, I think, initially, who really want to go for this option. In terms of the time spent and the acceptability, most participants spent less than 40 minutes at an injection site visit. The appointment duration decreased by 30% from month 1 to month 6. So as people become more familiar with this as a treatment, their visits become speedier. And overall, 93% of the injection visits occurred within 7 days of the target date. Now, when you looked at acceptability for people coming to the clinic or the practice to have their injection every 2 months, you can see in the sort of dark blue tealy color that the extremely acceptable rates were very, very high, around 43% at month 1, 45% at month 4, and a very small proportion in gray, you can hardly see it, saying that this was not at all acceptable. The top 5 concerns with daily oral medication were listed, and in fact, 45.7% had no problems with oral antiretroviral therapy. However, 35.6% said they felt they had to hide their medications from other people. 23% said that their daily medicines reminded them of their HIV status, and you can see the other reasons listed there. In my own practice, I have to say, feeling I have to conceal my medications is a top reason for people wanting to request injectable therapy when it's available. What about the concerns with the long-acting treatment? Most people felt that discussions with their medical provider was the best way to receive information about these regimens. But when asked about concerns around the injections, you can see the top concern was pain or soreness from the injection, reported by 40.4% of participants. Side effects from the injection, around 40%, but actually 27.6% said they had no current worries about the CAB and rilpivirine long-acting injection treatment. A top one for me, if I was in this situation, is the bottom reason listed here, but still reported by 1 in 5 participants, and it was scheduling my travel or my holiday to meet the 2-week injection window. And I think clearly very careful advice will need to be given about any oral bridging strategies for people who are going to be away during the window of time when they're supposed to receive their injection. So the take-home points here was that long-acting cabotegravir rilpivirine was observed to be an acceptable, feasible, appropriate treatment option for the maintenance of virologic suppression. The average amount of time people spent decreased over time, and 93% of injections occurred within the target date. The majority of participants were satisfied versus oral therapy and the oral lead-in phase, and the majority found that the clinic wait time, recovery time, and treatment information given was appropriate and acceptable. Moving forward to other long-acting treatments, we saw awaited analyses from the CAPELLA study, which looked at lenacapavir, the long-acting capsid inhibitor injected subcutaneously in heavily treatment-experienced patients. Now, you can see the study design here of the CAPELLA trial, which has been previously presented. I'm not going to dwell on this because what we want to look at here is the resistance development that happened in this study. If we look at baseline resistance in this highly treatment-experienced group, you can see the mutations per class on the left-hand side. So you have NUCs, non-NUCs, PIs, and INSTIs. And in terms of the proportion of participants on the right-hand side of that chart, 72 participants with 99% having resistance to NUCs, 94 to non-NUCs, 65 to INSTIs, and 83% to PIs. So this was really a very, very resistant group of participants, as defined as highly treatment experienced. When we look at the people who developed lenacapavir resistance in this study, we can see that 4 out of 36 participants in the randomized cohort met this criteria. And you can see these in some detail here. The resistance developed at varying time points, with 2 developing resistance very quickly at week 4. You can see then on the right-hand side that one of these had effective lenacapavir monotherapy with no active agents in their optimized background regimen. The other had 2 active drugs, but had problems with adhering to their optimized background. So again, was essentially on lenacapavir monotherapy. If we look at the 2 later failures, number 2 at week 10 and number 1 at week 26, again, these are similar reasons. So the first failure at week 26, this person had problems adhering to their optimized background and was receiving essentially lenacapavir monotherapy. And the second had no active agents in their optimized background regimen, again, effective lenacapavir monotherapy. And the reason we can say that is because, of course, the optimized background regimen was usually oral treatment. People were taking this on their own when they were at home, or not taking it in the case of the people who were not able to adhere, whereas the lenacapavir was being administered in clinic as part of the trial. So all 4 with emerging lenacapavir resistance either had no active agents in their optimized background regimen or were non-adherent to it and were therefore on effective monotherapy. These are actually the subgroup analyses looking at the efficacy. And the efficacy here is broken down by baseline CD4 count and viral load, but also on the right-hand side by the number of fully active agents in the optimized background regimen. And what we also saw in this study was that no differences were found between those with darunavir or dolutegravir in their OBR compared to those without or by use of ibilizumab. So trying to compare different agents in the optimized background regimen didn't really make much difference. It was how many active agents you had in that regimen that were important. So overall, the emergence of lenacapavir-associated capsid mutations was infrequent. 4 developed resistance, all with this M66M or I mutation, and all of the 4 patients who developed resistance either had no active agents in their OBR or were non-adherent to it and were on effective monotherapy. Now, we know historically monotherapy is not a good thing in HIV, and so it's almost unsurprising that lenacapavir monotherapy was not a sensible strategy. So I'm just going to finish with a few slides very quickly on COVID-19 vaccination efficacy and the pandemic impact on viral suppression in people with HIV. There are some studies looking at the immunogenicity of mRNA vaccinations against SARS-CoV-2 in people with HIV. They defined here people with severe immunodeficiency as having a CD4 count less than 200. People with a CD4 count below 200 and 500 are defined as having minor immunodeficiency, and no immunodeficiency was defined as being over 500. The outcomes here were the proportion of antibody responders, the magnitude of their response, the association between the CD4 count vaccination and the magnitude of the response, and the comparison of the immunogenicity in people with HIV with an unmatched control group of healthcare workers who were not living with HIV infection. I will skip through this slide, but again, this will be downloadable for you later on. Interestingly, the immunogenicity of vaccines was strongly related to the CD4 cell count at the time of vaccination. A lower CD4 cell count significantly and independently predicted a poorer immune response to SARS-CoV-2 vaccination. So in this scenario and with this vaccine, it does suggest that people with lower CD4 counts who are living with HIV should be prioritized for COVID vaccination, but also, if previously immunized, perhaps to receive a third or booster dose. This was a separate study that looked at the follow-up of people who'd received at least one dose of another mRNA vaccine who completed a questionnaire within 1 week of each dose. They were looking here at symptoms, so whether people had worse symptoms if they were living with HIV, and actually there was a higher rate of moderate symptoms after the first dose of vaccine in female, younger, and virally unsuppressed participants. There was a lower rate of moderate symptoms in those with a CD4 count below 200. And these data were comparable with those compiled from a cohort of healthcare workers who'd been vaccinated with another vaccine. What about the outcomes of people who had less frequent monitoring during COVID-19? So this was a study this was from the UK, looking at the outcomes for people who were living with HIV, who had a viral load below 200 copies on antiretroviral therapy before COVID, and compared this with outcomes during the COVID-19 pandemic period, so from March 2020 to February 2021. This was a data set of about 2,500 participants who'd been suppressed before COVID, and of those, about a fifth did not have a viral load test during the COVID-19 period. 2% had a viral load that was reported at above 200 copies during COVID-19, and of these, 2 actually did have emergent resistance. So all in all, less frequent monitoring seems that it may be safe, but nonetheless, we need better ways, I think, to identify those for whom less frequent monitoring is potentially harmful. So in terms of take-home points, the immunogenicity of vaccines is strongly related to the CD4 cell count at the time of vaccination. Low CD4 count is significantly and independently associated with a poorer immune response to SARS-CoV-2 vaccination. The safety and vaccine-related symptoms in people with HIV is comparable to those from a cohort of healthcare workers who were not living with HIV infection, and the severity of adverse events may be dependent on both CD4 cell count and on age. During the COVID-19 pandemic, most virologically suppressed people with HIV remain suppressed, even with a reduced HIV viral load monitoring frequency in this UK cohort, but a concerning number may have been lost to follow-up, and a small minority may have developed virologic failure with resistance. So I think just on time, I'm going to stop there and ask Jessica to moderate any questions you may have submitted in the chat. I think it's okay if we do run over by a few minutes to take your questions. Please do pop them in the chat now, and thank you very much indeed for your attention.
All right, thank you to Dr. Barber for that excellent presentation. We do have some questions coming in. The first is from Carly. In the prospective trial, how did they define historical 184V? Was it further out than 5 years?
So this was you're talking about the BLIC American data, the SOLAR 3D study. From memory, they did not stratify the time point of the development of the M184V in that study. So it was just any record previously of an M184 mutation. It wasn't broken down by greater than 5 or less than 5 years. That was in the French data set.
Next question is from Ulrich. Do you expect a higher number of late presenters after the end of the pandemic?
I'd love to have the opportunity to be speaking to you face to face and ask you what you've been seeing in your own practice. We certainly have seen a spike after the first wave of COVID last year in late presenters admitted to our ward. We also saw a number of seroconverters, people that have been unable to access PrEP during the first lockdown. We've not seen quite such a jump in new presentations after the more recent lockdowns. So I don't know if people have got more confident about accessing healthcare services despite varying country restrictions. But I think all in all, the answer is yes, we would expect that a lot of people have delayed presenting to healthcare settings for HIV testing and for a number of other medical problems. Certainly top of our list is we continue to see a number of late presentations of cancer, for example.
Okay, and our last question from Carly. In patients who have CD4s in the 200 to 500 range, would you suggest providing a third dose to these folks? In less than 200, we do provide letters for the third dose already.
Yeah, it's a great question. I mean, again, I think it depends on your setting, Carly. My personal feeling is that I would love us to have global equity of access to COVID-19 vaccination, because I think we're not going to be through this until more people around the world have access to vaccination. And that means at least getting their first and second doses in. Nonetheless, based on the data we have so far, I do think that people with a CD4 count certainly below 350, a little bit more contentious maybe about the 350 to 500 range, but would warrant a third dose. We're currently undertaking a serological monitoring study here, and we are finding that those with a low CD4 count below 350, or those usually with a solid organ transplant, do have rapidly waning antibody levels. Now, we don't know if those necessarily correlate to protection, but we do think it's the right thing to offer those people a third or booster dose.
Thank you very much to Dr. Barber, and thanks to you, the listener. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.